Hi, y'all, and welcome back. This is Professor Truelove's Concepts for Nurses series. In this episode, the last of the neurological episodes, we will be discussing brain tumors and brain death, with a little bit of dialogue about abscesses thrown in just to round it out. As always, sources for this section include Iggy's Medical Surgical Nursing 9th edition and Soul's Introduction to Critical Care Nursing 7th edition. Brain tumors, by definition, are space-occupying lesions, and therefore they can cause increased ICP. Brain tumors can arise anywhere within the brain structures. Primary tumors originate within the CNS. Secondary tumors result from metastasis in other parts of the body. These tumors are named according to the cell or tissue where they are located. However, cerebral tumors are the most common. Primary tumors rarely metastasize outside of the CNS area. Secondary tumors are usually from areas such as the lungs, breast, kidney, and GI tract. But regardless of the classification or type of the brain tumor, these tumors expand and invade, infiltrate, compress, and displace normal brain tissue. This leads to cerebral edema, brain tissue inflammation, increased ICP, focal neurological deficits, obstruction of cerebrospinal fluid flow, and pituitary obstruction. The classifications tumors go like this. Tumors are classified as malignant or benign. The tumor's location places it in a class of supratentorial or infratentorial. Supratentorial tumors are located in the cerebral hemispheres, whereas infratentorial tumors are in the areas of the brainstem structures and the cerebellum. The tumor's anatomic origins place it in a class of cellular, histologic, or anatomic terminology. Further, we should discuss the types of tumors. Gliomas are malignant tumors and account for 60% of all brain tumors in adults, with a peak incidence occurring between ages of 40 and 60. They quickly infiltrate and invade surrounding tissue. They are graded between 1 through 4, with very poor outcomes for a grading of 3 or 4. Meningiomas are a type of common benign brain tumor with a peak incidence at age 50. It happens in females more often than males. This type of tumor is encapsulated, globular, and well demarcated. They can, however, cause compression and displacement of brain tissue and tend to reoccur. Pituitary tumors, of which the most common type is an adenoma, may cause endocrine dysfunction, and they present signs that include visual disturbances, loss of hair, diabetes, diabetes insipidus, sterility, visual field deficits, and headaches. Acoustic neuromas compress other cranial nerves, specifically cranial nerves 7, 5, 9, and 10. Symptoms include hearing loss, tinnitus, dizziness, and vertigo. Metastatics account for 30% of tumors. Cancer cells from the lungs, breast, colon, pancreas, and kidneys are the most likely culprits. Signs and symptoms of brain tumors are headaches that are usually more severe on awakening in the morning, nausea and vomiting, visual symptoms, seizures, changes in mentation or personality, and papilledema, that is, swelling of the optic disc. Neurological deficits result from the destruction, distortion, or compression of brain tissue. Infratentorial, that is, brainstem, can lead to ataxia, autonomic nervous system dysfunction, vomiting, drooling, hearing loss, and vision impairment. Supratentorial, or cerebral tumors, can lead to seizures, paralysis, memory loss, cognitive impairment, language impairment, or vision problems. Nonsurgical management includes radiation therapy, chemotherapy, analgesics, dexamethasone, phenytoin, ranitidine, and stereotactic radiosurgery. The outcome of treatment of brain tumors is to decrease the tumor size, improve the quality of life, and improve survival time. The type of treatment selected depends on the tumor size and location, the patient's symptoms, the general condition, and whether the tumor has occurred again. Radiation may be used alone, after surgery, or in combination with chemotherapy. Chemotherapy may be used alone, after surgery, or in combination with radiation and surgery, and it will depend on the tumor progression. Stereotactic radiosurgery is a modified linear accelerator using accelerated X-rays, a particle accelerator using beams of protons and isotope scenes implanted in the tumor, also known as brachytherapy. The gamma knife and the cyber knife are the newest types of treatment. So your priority interventions include to compare and contrast with interventions for a traumatic brain injury, because essentially you have a brain injury here, and you're also having brain mass or cerebrospinal fluid or blood being displaced. So many of the interventions and assessments are very similar. However, you need to add to that things such as radiation therapy, chemotherapy, and these surgical interventions are actually very similar because a craniotomy is the procedure most often used. Postoperative care includes analgesics, including codeine for headache and acetaminophen for fever or mild pain, dexamethasone to control cerebral edema. You may also use glucocorticoids for the same purpose, that is, to reduce the edema, phenytoin and other AEDs to prevent or reduce seizure activity, histamine blockers such as ranitidine or PPIs in order to decrease gastric acid and prevent the development of stress ulcers. So you should continue with postoperative care, including positioning, monitoring the dressing, monitoring laboratory values, and ventilating the patient as needed. A common surgical procedure used is supratentorial craniotomy. The tentorium is a tent-like covering of meningeal layers that separate the occipital lobe of the cerebrum from the cerebellum. It provides access to frontal, temporal, parietal, and occipital lobes. The suture line is located just below the hairline, and so is therefore relatively easy to hide. Post-op care for supratentorial craniotomy means that the head of the bed should be elevated between 30 and 45 degrees. The patient may be positioned on either side, but if a large tumor is removed, not on the operative side. They should be out of bed between 24 and 48 hours postoperatively. They have a greater risk for seizures. Fluids should be limited to 1,500 milliliters for the first 24 hours. The patient's dressing should be monitored for drainage, and the nurse should be aware that there is a risk for meningitis. In contrast, an infratentorial craniotomy, the site of surgery is below the tentorium into the infratentorial compartment. The incision is made at the nape of the neck. Because of the different location and the different approach, the post-op care for the infratentorial is quite different. In this case, you should avoid flexing the patient's neck. Keep the bed flat. The patient should be out of bed in 3 to 5 days postoperatively. The patient should be kept NPO for the first 24 hours after the surgery, and the nurse should realize that there will probably be a decreased gag and swallowing reflex. Postoperative complications of craniotomy include an increased ICP, hematomas, hydrocephalus, respiratory problems, wound infection, meningitis, and fluid and electrolyte imbalances. Recall that meningitis is the inflammation of the meninges and may occur as a result of the surgery or a wound infection. It can also occur because of CSF leak or contamination during surgery. Diabetes insipidus is most often seen after supratentorial surgery, especially procedures involving the pituitary gland or hypothalamus. It is the failure of the posterior pituitary gland to release antidiuretic hormone, or ADH, which lead to the failure of the renal tubules to reabsorb water. The patient's urine output increases dramatically up to 10 liters per day, and the urine-specific gravity drops below 1.005. Urine osmolarity decreases, whereas serum osmolarity increases. That means the patient may become dehydrated and hypovolemic. Shock may develop rapidly if this condition is left untreated. Fluid therapy to replace urinary losses and to prevent dehydration may be accompanied by having the patient increase oral intake or by using IV fluids. Hormone replacement may be used if the loss is greater than 6 liters in 24 hours. The preferred hormone is aqueous vasopressin, which is a short-acting, that is, only 6 to 8 hours, acting agent. Desmopressin may be administered for long-term therapy replacement. SIADH is treated by fluid restriction, which is usually sufficient to correct the hyponatremia. Brain abscesses also take up space within the skull. A brain abscess is a purulent infection of the brain. The findings may be atypical at initial presentation, so therefore diagnostic assessment is required to determine the fact that the patient in fact does have an infection. Treatment is you need to compare and contrast with other types of therapies for reducing or maintaining ICP, but also antibiotics need to be added. And if needed, surgical intervention to drain the abscess may be needed. Despite the best efforts of the healthcare team, brain death can still occur. It's important, therefore, that the healthcare team understand brain death criteria. This includes a Glasgow Coma Scale of 3, the presence of apnea despite no respirations being provided, no pupillary response, no cough or gag reflex, no ocular vestibular reflex, no corneal reflex, and no oculocephalic reflex. You should know that the last 4 criteria are done at the bedside and look to see if basic brainstem functions exist. Without cough, gag, oculovestibular, corneal, or oculocephalic reflexes, this indicates that the brainstem is gone, and therefore brain death has occurred. That does conclude this episode and the end of the neurological series so far. Please stay tuned, because coming soon is our cardiovascular series. In the meantime, steady heart, and we'll see you then.